Good morning. This is Dr. Stephen W. Stites, Chief Medical Officer here at the University of Kansas Health System, back in the saddle again, right here, broadcasting live with you from the Dulce Simons Jr. Family Broadcast Studio. Delighted to be back with you after our vacation last week, fly fishing in the Colorado Rocky Mountains, which was the best. Welcome back to Open Mics with Dr. Stites. You can find me here every Wednesday talking about all things COVID. In studio with me today is Dr. Heath Latham, specializing in pulmonary and critical care medicine. I've known Dr. Latham for approximately very many years, an outstanding physician, good friend, and delighted to have him here with us. Joining us virtually is Dr. Jonathan Pike, and here's my first Star Trek reference. I'll try not to call you Christopher Pike, captain of the USS Enterprise before James Kirk. I'll try and avoid that today. He is with Great Bend Family Medicine, and he's not with the Enterprise, as it turns out. As the Great Bend campus has seen more COVID-19 patients in recent weeks, finding a hospital to transfer more serious cases has been a challenge. We'll learn more about how our doctors here in Kansas City are trying to help and about what's going on out in Great Bend and in western Kansas. We're going to chat with those doctors in a moment. But Dr. Dana Hawkinson, Medical Director of Infection Prevention Control, he's not quite here yet. He'll be joining us shortly with a look at this morning's COVID patient numbers. Hint, we're still doing better than we were before I left town, which I think means I should get to go on vacation more often because I think it means less COVID to Kansas City. That's really a win for all of us. Maybe I should check that out. First, though, let's see if we have any reporters on the line with questions this morning. Okay, I'm not hearing anything from anybody.
Dr. Stites, I do have a question.
I know you do. Hey, Jess, how are you?
Hi, nice to see you again. Glad
It's good to be back. Although my hair's kind of a mess, I need to comb it. Okay, I think I'm done. It takes me longer than Dr. Pike. How about that?
You just blew in here. I love that. Okay, Donna has a question, and I was curious your thoughts about this. Dr. Alt was on yesterday and talked about that the Pfizer vaccine for kids 5 to 11 might be available by Halloween. He mentioned it might be now available by Thanksgiving. That sounds like good news, but the question is, normally 1 month may not be a big deal, but this is a harder pill to swallow because family gatherings will be really ramping up, and now you're going to have kids with unvaccinated kids gathering around other people that are vaccinated. So, kids won't have that opportunity to be fully vaccinated. Just what are your thoughts about that?
Yeah, I think it'd be great if we can vaccinate kids who are between 5 and 11 years old. Obviously, we already can if those are 12 and older. The challenge is that Pfizer's not announced when they're going to supply the information for their EUA. Until they do that, the FDA can't even act. What they've done is make a public announcement that the information looks better. There's been some early publication of information and data, but there hasn't been a submission for an early use authorization to the FDA yet. Until that happens, we're not going to be able to act on it. The FDA can't act on it. And because it involves kids and because there were some concerns about pericarditis and myocarditis, and even though the CDC has said in the data we've reviewed, the incidence of myocarditis and pericarditis looks to be much lower in those who are vaccinated than in those who have COVID amongst young children, and that it appears to be very self-limited. There's no way they're going to just brush through that information. They're going to want to make sure they've had a good chance to look through it. We're going to have to wait for the CDC Advisory Committee on Immunization Practices to make their recommendation, and then I think we'll get that early use authorization. But it's probably is going to take a couple of weeks or maybe a month to get through that information. We just need to get Pfizer to submit that as soon as they feel like they've got it ready. Obviously, we'd all like to have it sooner rather than later, but we also know we have to trust the process to make sure we keep everybody safe.
Okay, so Shane from KCTV5 has a question for you. A major local school district decided this week to not require vaccination for teachers and staff, saying that they were afraid that it could lead to staff quitting. Do you think that that's the right move? Should school districts require staff to get vaccinated, and would that help the local COVID numbers?
Yeah, I think having everybody vaccinated helps the local COVID numbers. If we really want to be out of this crisis and not wear a mask, by the way, when I was in Colorado, I didn't have to wear a mask. I was outside almost the entire time. And then the first thing I did when I put on my mask back when I got to get ready to go to the airport is my glasses fogged up, and it reminded me how I don't like always wearing a mask all the time. But you know what? It is still the right thing to do. And the reality is we can prevent the spread of COVID, even with the Delta variant, if we just choose to wear masks as often as possible. And if we get everybody vaccinated, if we got everybody vaccinated, I'm kind of hopeful that we wouldn't have to even wear a mask for much longer. But on the other hand, if you're in a school district with faculty and with employees around kids, man, I do think it's right to be vaccinated and to wear masks because we know we have to stop the spread of COVID-19. Here's what I'm afraid of. We've bent the curve in Kansas City again, right? And the Delta variant came roaring through. We had lots of crises around that. And I think that what's happened is with masking, we've watched the numbers begin to decline, and that's a great thing. The question is, are we going to stay masked, or are we going to all take off our masks? If we take off our masks, we're going to run the same risks as we did last fall when we saw the numbers begin to shoot up and we had the big crisis in December, the biggest wave in December and January. How can we prevent that? We can prevent that from getting people vaccinated. Who do you want to get vaccinated? You want to especially vaccinate those who are vulnerable. Who are some of the most vulnerable people who can get sick and have trouble with the disease? Clearly, educators are amongst that group. And so really would encourage everybody who's in an educating role, and everybody, period, really, to be vaccinated, but our frontline teachers and folks working in school districts where people are gathered together, a lot of folks in a crowded area, man, I would absolutely want to have everybody be vaccinated. Just to say, I think every industry faces a challenge of potentially losing people who have, when there's a vaccine requirement. What we know is from recent stuff that has come out by different about healthcare organizations, where that there have been a lot of vaccine mandates that people are losing about 1 to 3% of their workforce. You say, well, that's a small number. It may be a small number, but man, at a time of healthcare shortages, you really want to make certain that you have everybody there. But here's the deal. There is I think a moral quandary here, and the quandary is that if we believe in the science at all the other times that we take care of patients, why would we not believe in the science at the time of COVID inside a healthcare organization? So we've made the decision that we have a vaccine requirement. Secondly, if you're a patient, you deserve the safest possible environment to get care in. Well, what's the safest possible environment? Being taken care of by somebody who has been vaccinated or someone who hasn't been vaccinated. The science shows us there's absolutely no question about that. You're safer being taken care of by somebody who's been vaccinated. I had a great letter that came to me about a month ago from a patient who said, I'm one of our cancer center patients. I love KU. I feel like I get great care there, but I'm concerned you don't have a vaccine requirement and I have to get chemotherapy, which means that's someone who's especially at high risk for a bad outcome from COVID-19. They have to get chemotherapy and they come in, they go into the chair to get their infusion, and they don't know if the people who are giving them those infusions have been vaccinated and therefore are less likely to transmit COVID. Because we know that if you've been, even with the Delta variant, you've been vaccinated, it reduces the risk of transmission by about 50%. So when you look at that letter and you think, gosh, wouldn't we want to take care and protect that person? Well, of course we should. And so as a result, we need to make sure that everybody inside healthcare has been vaccinated. And I think the same thing is true in schools, right? If you're a child and you have a vulnerable parent home or a grandparent, et cetera, don't you want to make sure you've been protected from transmission as much as possible? And I think the answer to that should be yes, because that is how we take care of each other. So do I believe everybody should be vaccinated? You bet. Have I been vaccinated? You bet. Am I going to get a booster shot when it's my turn? I had the Moderna vaccine? You bet. And am I going to get the influenza vaccine? You bet. So at the end of the day, take the right bet. Bet on your health, bet on your safety, bet on the people you care about. Get vaccinated. Any other questions, Jess, out there? No, Jess, I can't hear you.
Yeah, none over here. Go ahead.
All right, let's turn to our guests for just a minute. We have Dr. Latham and Dr. Pike, as we introduced earlier in the program. Hey, every hospital in the country is feeling the effects of COVID-19. It's making it even harder to find a place to get critically ill patients to receive care. We know that our transfer center dropped from about 65% of patients accepted down to 25% of patients being accepted, while the number of calls had accelerated. And that's simply because we didn't have enough beds. But we've really made a lot of efforts around trying to help, especially with Great Bend, because they don't have an ICU. And our pulmonary critical care team has been trying to help with that because they help they run our medical ICU and really are pivotal moments in time around the whole COVID-19 crisis. Dr. Latham and Dr. Pike, describe your partnership and the impact this partnership is having on your patients. So first, let me turn to Dr. Pike, who is a family medicine physician out in Great Bend. And again, I've not called you Christopher Pike yet. I've not called you Captain. That's impressive.
I would take Captain greatly, and I'd also second your choice of vacation locations. I was actually in Colorado 2 weeks ago with a mini residency reunion, and it was great to be in fresh mountain air and to be free of the duty of wearing masks for a little bit. As far as being in Great Bend, there hasn't been an ICU for a couple of years now, prior to me starting here 3 years ago. And I think in general that was a hard pill to swallow coming out of residency and being used to doing some of that ICU level care. And now that we see ourselves facing this national crisis, where patients deserve the best care that they can have close to home, and now there's really no place to get them to go. The challenges have been, it's hard to see people sick and tell them that they can't stay here. So with this relationship now with the health system, it's been an absolutely phenomenal benefit to our patients. I've had a chance to meet with Dr. Latham on multiple occasions, and as we were looking through things and through our relationship with Kansas City, it just made sense to say we don't have a place to go, but let's use the technology and the resources that we have available and get the best information and the best knowledge to our patients here locally.
So, I think that does make sense. And I'm going to turn to Dr. Latham. But first, I have a question for you. You used to have hair the last time I saw you. What happened to that? Is that a COVID effect? Because I blame mine on my kids in COVID and on Jessica Lavelle sometimes.
Yeah, so part of it is a COVID effect. Part of it is a lighting effect. I keep it buzzed really short, but there wasn't much on top left to buzz. So.
Okay, so I think we should both blame Latham because he has hair on top. What do you think? Can we complain about him for just a minute?
Yeah, let's complain.
Excellent, Latham. It's your fault. So tell me, talk to us a little bit about the relationship between our ICU, Great Bend, how we've been taking patients, and how you've been trying to help folks.
Yeah, so as you and Dr. Pike both alluded to, we knew that it was becoming more and more difficult for our rural-based hospitals to transfer patients they would normally transfer to higher levels of care, and that they were going to have to hang on to these patients for longer than they are typically used to. And so how could we assist them? It was an advantage that our health systems both share the same EMR, and so we could see labs and vitals and imaging of our colleagues' patients in Great Bend. And so we quickly were able to set up a system by which our Great Bend hospitalist colleagues could call into our transfer center if we did not have a bed for their patient to get into. Then they would reroute to one of us, pulmonary critical care, to do a critical care consult with them. It's not a formal EICU or anything. I think that's that's where we would like to be to help places like Great Bend to really be there. But we can hear what they're seeing. We can see, the EMR, et cetera, and we can provide advice in terms of what additional therapies or continued therapies our colleagues can continue to do. While most of the time they continue to try and look perhaps for places for transfer, but maybe also they are able to stabilize the patient, and the patient maybe slowly gets better and then doesn't need to leave either, which is a win for the patient.
That is a really big win for people not to have to leave in the middle of that. So, Dr. Pike, tell us, how much time has it been taking to try and secure a transfer, especially if KU's full, which unfortunately has been happening more often than we would like?
Yes, it's definitely been a challenge. And so I would say the fastest that a transfer is secured is within 2 hours, and that's assuming that you get the right higher level of care at the right time, that they had a discharge bed open and you were just the right person on the call. Sometimes I think it's like a radio show where the seventh caller gets the prize, and you have to hope that you're the seventh caller at the right time. I know from our emergency department, for people who have pressors initiated or intubated, because we're not able to keep any intubated patients here at this time. Sometimes they're taking half their shift or more to try and supervise or secure a transfer, and that's hard for the other people that are coming into the emergency department when we already have a limited bed space there, a limited bed space on our floor. limited staffing. There's a lot of, I think everywhere's feeling the impact of staffing shortages as people kind of get burnt out, and if they don't have to work, then they choose not to work. So we're seeing those impacts as well.
So, Chris, talk to us a little bit about the Grapevine Hospital. Describe it to us a little bit, because I bet most of our audience doesn't know how many beds you have and what kind of capacity is there, et cetera.
Yeah. So what we're able to staff most of the time is our technical capacity is 29 beds. With our staffing shortages and things, we're closer to around 20 to 25 beds. Some of those are surgical, some of those are obstetric, some of those are pediatric. And so what our hospitalist volume is typically is usually a max of 18 to 20. Over the weekend, we reached 17 or 18, and just under 50% of those patients were COVID patients. Thankfully, they were responding well to the initial therapies and didn't need higher levels of care, didn't need intubation. And I think only 2 people needed to be on BiPAP support. But when we're looking at one person rounding on that type of a census, it's a lot to have close to a third. Right now, I would say between 33 and 50% of our census is COVID positive patients.
That's a lot. How are things been going, and how are people responding to masking or to vaccinating, and how's that going with the medical staff in Grapevine? Yeah. So like you mentioned before, I think everyone's about as tired as anyone else of wearing masks, but I think people are trying to be respectful and doing the right thing. And now we have flu season coming up, and we have the plan to administer our influenza vaccines. I think also by nature of just being in a smaller facility, the percentages stand out more as far as people who are traveling and come from different facilities with different policies. And so I do want to give a shout out to our administration and our unit managers who are very diligent in working to ensure the uniformity of system standards here on our campus. Yeah, I think that's right. And I just to say a big shout out to you and your team for everybody that's been working so darn hard in Great Bend to help provide great care to that community. So turn to Dr. Latham. So Heath, you get these calls from all around the state of Kansas. What can we do to help these hospitals, and what have you give us some examples of some of the type of patients you've brought in?
Well, it's certainly COVID has been a big indication for transfer. There was a very small hospital, Northwest Kansas, had tried over 20 places to get a ICU bed on a patient who needed very high levels of oxygen and was on the verge of needing intubation. And unfortunately, needed to travel about 70 miles to get to a place to then get on a flight to get here. Ultimately, the patient did get here, and we were able to provide care for that patient. Unfortunately, there were several other in that hospital that also needed to go to other places. And so, as you have alluded to, all these hospitals are very packed full, and they're packed full of COVID, and they're packed full of critically ill non-COVID. And just the total numbers throughout these hospitals just don't allow for patients to easily transfer as once was the case.
Yeah, that is really true. And with fewer staff across the country, it's become even more challenging because we can't staff all the beds all the time. And we do a pretty good job of that here. But, man, there are a lot of hospitals I know that really are struggling, and it's tight here. And I think that that's one of the things that concerns us so much. And then people say, well, let's have a vaccine requirement, which absolutely we have to do. But could you, health systems have lost 1 to 3% of staff. Does that affect you? On the other hand, if people are sick because they have COVID, they can't work, so that affects you too. So ultimately, still, I think the right thing to do to have that vaccine requirement. So, Dr. Pike, as you look down the road and think about things, you still have regular patients to take care of, people who don't have COVID. How can the health system be of the most benefit to you on a daily basis to help support you in Great Bend? That's a broad-ranging question. It wasn't on the script, but you know me, I never go by script, so.
That's okay. I was prepared. Two of the things that I'm really excited about that I've seen development recently, especially from the inpatient side, is being able to do formal infectious disease consults, because I think that's been one of our biggest challenges, not necessarily related to COVID even, but when we get all different types of bacteremia, and I feel like they are either renaming or different strains, and it's just, I'm fairly comfortable with the saying antibiotics, but we want to be good stewards of the antibiotics, get the right antibiotics, and minimize the length of time that patients need that. And so the telehealth consults that we've trialed and are starting for infectious disease, that's a tremendous benefit to our non-COVID patients. I think that we've had very good success when other facilities are full from staffing, or I would say other facilities, being more geographic facilities, are full from staffing components or from COVID volume. Our non-COVID patients have had good success getting transported to Kansas City as well, which has been a tremendous blessing for them to get that level of care. And then what I heard about 2 weeks ago would have been the upcoming lung cancer screening, low-dose CT, as we are moving forward towards that in collaboration and being able to use the Kansas City resources and the team that's there to take care of our patients who are going to need long-term surveillance for lung cancer screening because of their smoking history. And so those are just some of the immediate benefits that I've seen in the past month.
Yeah, that's great. I do have to share one thing, though, with you. Those infectious disease guys, I don't know what they do. Have you ever been to an infectious disease meeting? I've been to a couple ID meetings. I even went to an ID journal club a few times. They sit around and they talk about how they name different bacteria. And then, just as you understand it, it's like they don't have enough to do. They change the names of the bacteria. And then you got to try to figure out what the heck's going on. And then you get these wonky names for antibiotics. Oh, wait a minute. Hawkeye's here. Oh, hey, Hawk. How are you, buddy?
It's called job security. We also wash our hands a lot during those
you do wash your hands a lot. So. That's true. So, hey, Hawkeye, how are our numbers today?
Hi. Yeah, the numbers, are good. We've been hanging in that high 20s, low 30s. Right now we have 31 active infections with 9 in the ICU and 7 on the ventilator and 8 total vaccinated. We have 33 additional patients that have met that recovery criteria, but I think the story is about the vaccinated. So in our ICUs, one of them is vaccinated.
Yeah, not very many.
But, that patient, brain surgery and cancer, the other patients in our other medical ICU, those 7 patients, none of them are vaccinated. And also, we should state that the majority of our patients that are vaccinated, again, looking at the ages, 88, 88, 81, 94, one that's 52 and 60. But again, we have underlying chemotherapy, multiple myeloma, diabetes mellitus. So a lot of different problems, other cancers as well. So these vaccinated people, I think, are better protected because they are vaccinated. They could be much worse. They are obviously not in the ICU, but they have those significant underlying issues. So.
Yeah, I saw, I was in a meeting yesterday when we had one of our graphs that looked at what's the average age of the unvaccinated patient, 52, 53. What's the average age of the vaccinated patient? It's about 68. Okay, so folks, there's the take-home message, right? If you want to stay out of the hospital, you want to stay well, A, take care of yourself, B, get vaccinated, and if you're in a high-risk category now, and if you had a Pfizer vaccine, get a booster.
Absolutely.
What about the Moderna vaccine?
Yeah. I mean, again, all of these vaccines continue to elicit great protection against coming here to the hospital, going to the ICU. We do expect there will be more guidance about Moderna. And just as we had said a couple weeks ago, it may be the direction that if you did get mRNA vaccine, everybody may be getting a third dose. We talked about this yesterday on our booster dosing meeting here at the health system, but then later on when I got home, I also saw in the Washington Post that Dr. Fauci had said that as well. And so I think that's the direction we're going. Is it necessarily for protection? Because we know that they continue to offer good protection. That is one of the reasons. The other reason is they also do believe that it may help decrease transmission even more, and we know that is so vitally important.
I think it is. And, New England Journal of Medicine article last week looked at the rate of decline in the Moderna vaccine. In fact, it's still very effective at 5.2 or 5.3 months. And so it raises the question, when will you get another booster from Moderna? And I think, my guess is we're going to settle in on one number for all the vaccines, because otherwise it's going to be really confusing, but we don't know that yet until they come out about it. The other big development I thought last week, I was not here last week, there are lots of big developments, Pfizer, kids, and then the J&J vaccine, that second shot of the J&J vaccine looked really good for efficacy. So, man, I think the boosters are around the corner for really all the vaccinations, and that'll help keep everybody safe.
Well, welcome back, and later on we will have a surprise for you coming
back. Boy, I love surprises most of the time. All right, Jess, let's see what questions are out there from our listening audience.
Yes, we've got some good ones. Okay, so my first one is from Isaac. Question for our guest. Is Western Kansas seeing some of those big outbreaks like we saw in the meat plants early on in the pandemic?
That's a great question. Dr. Pike, have you been seeing some outbreaks from meat plants or other places where folks may be gathering and working?
I have not seen the follow-up outbreaks from meat plants like there were a year ago. What I do tend to see is that Central and Western Kansas experience more of a lag time from what you guys experience in the Kansas City area, and that tends to be about 2 to 3 weeks that our peaks seem to follow and then flatten out at that point in time. And I think that's just because in rural Kansas we're social distanced by nature, so it takes a while to get to us. But now that we're in school and activities and everything, once it does get here, then people are going to experience that surge. And so hopefully since things are flattening out in Kansas City, that means things are close to flattening out here too now.
Yeah, we do like the flattening falling numbers. Those are great things, and hopefully they'll continue to fall. I'm a little nervous about people getting a little cocky around masking, especially indoors, taking the masks off, big gatherings, and we saw what happened last fall when we did that. Jess.
On that topic, while you said something about masking, Kay says her question of the day is, what kind of mask does Dr. Stites and Dr. Hawkinson wear in the freezer, and are those the kind of masks that we all should be wearing?
That is a great question, Hawkeye. Yeah. Maybe we should go back to the freezer again because we demonstrated different masks.
I think you had a variety.
We did. We had both cloth masks, we had face shields, which don't work. We had cloth masks, and we had the common surgical masks you get at the pharmacy and you see us wearing most of the time. Oh, look at them. They've already got the freezer video up. No. It's like they were prepared. What do you think? The differences in masks. I think they're all good.
Yeah.
I mean, with the Delta variant, the surgical masks may be better than the cloth mask, but they're still all really helpful.
So I think that's the important thing is we do know, and there is good data to back this up, that there are reductions in protection of some of the masks, especially for the wearer. But there's also good data to support the fact that they all still continue to do what they are supposed to do, and that's create that barrier. Even the cloth masks, the surgical masks, and of course the N95. But the important thing there, and we have stressed that as well, is the fit of those masks. And so if you can get the fit as tight around your face as possible, that is going to block more of those droplets from getting out into the environment.
Scott wants to know, he's a healthcare worker, if my employer has a vaccine mandate, when can we expect the mask requirement at work to go away? After 20 years in healthcare, with my experience, I just don't see that masks will ever go away within healthcare. Can you add to that?
Yeah, that is a really great question. Let's go around the audience and see how everybody feels about it. So first of all, we do wear masks in healthcare. We've been wearing masks for approximately a very long time, much longer than how old I am, and I'm old. And so I think that the masking question, we will continue to have people mask because in healthcare you're taking care of vulnerable patients. And so what we've watched is our infection rates drop within the hospital. So I think in our clinical areas, certainly if you're taking care of people with highly resistant infections, we'll still be masked. We've been doing that for years. In the OR, you're going to still be masked. We've been doing that for years. The question is, when will, from a healthcare perspective, And I think that's different than you're over in the administrative areas. But if you're in the healthcare areas, like we're taking care of patients actively, will we just stay in masks on? I don't think we know the answer to that yet, Hawkeye. I don't know, because we don't know the fate of this crisis altogether.
Yeah, I would agree. Initially, I would have said we probably never will go back to not wearing masks. But who knows? As we get further years into this now, I don't think this is going to be the short step. The short term is going to be getting everybody vaccinated and really making sure that we are not contributing to somebody's morbidity and mortality. So I think it will take time as more of us, number one, do get vaccinated, number two, do see the infection or do get the infection, continue to get that immunity. I think we are all hoping that eventually, but I don't have a good time frame, that this may turn out to be something like the common cough and cold coronaviruses that we already know about. It's just a matter of when will that happen. But the separate question is, the question that was asked is, when do we think we'll go back to not masking? For the short-term foreseeable future, I don't see that.
Yeah, I don't either. And I think the question is, once you have a lot of people vaccinated in your place of employment, do you still need to wear masks? I think the answer to that question right now is yes. Until we learn more about the COVID crisis and until we learn more about vaccination and the impact on disease transmission, especially after boosters, I think the answer will be yes, because you're taking care of a vulnerable patient population. I think that's what you have to remember. The folks, this is really masking vaccination. It's about you, but it's not only about you. It's really about everyone else. And our job is to keep our patients safe and to keep our staff and our team safe so we can take care of folks. The way we do that is we get vaccinated and we wear masks, because masking is remember that Swiss cheese model? Yeah. All the layers you could do to help protect yourself from spreading to someone else a deadly disease. And if you're already sick and in the hospital, getting COVID-19 can really be deadly. Talk about some of the masks you wear over in the ICU, because you have that funny looking thing that makes you look a little like a walrus or something, or maybe a
we got the whole half-face respirator.
You look like the Borg. Another Star Trek reference, Live Long and Prosper. You look like the Borg.
Yeah.
You look like the Borg at baseline. I don't know.
Yeah, we're in the ICU and we're dealing with our COVID units and taking care of those patients on ventilators or on heated high-flow nasal cannula where there's aerosolization. Those patients, we always wear N95 maskers, full hood PAPRs, which you may see people use those for like sandblasting, etc.
Yeah, that makes you look like a stormtrooper, to make my Star Wars reference for the day.
That's correct. And then we have these, most of us are wearing called half-face respirators. You may see, they look very similar to perhaps when painters are doing their stuff. You can see it there on the screen. Those are our half-face respirators. They're reusable, and so we just have to replace the little filters, those gray things that are right there on the side. They're a lot more comfortable, in my opinion, than the N95s, and so I'm glad that we have those as well. I agree on the masking side. I think what will come out of this, regardless of COVID, that I think we'll probably end up finding that there's less infections across the board if we're wearing masks in the health in the units in the care units. And so I agree with everybody and Scott who asked the question that we will probably be wearing masks in the healthcare setting for a long time to prevent us from causing infections to our patients, and patients obviously infecting us as healthcare providers, so that we don't disrupt the workforce either.
And Dr. Pike, I think you guys are still wearing masks out in Great Bend as well.
Yes, that's correct. And the predominant one that we have, we'll use, some people will use N95s and some people will use the PAPR devices for our COVID patients. But then for all of our simple patients, depending on respiratory or not, some people will still use N95s for non-COVID patients. And otherwise simple face masks or the simple surgical masks that we've used for as long as I've been a medical student.
Yeah, so and hopefully that's not going to be true in general public and most businesses. I think hopefully we get through the COVID crisis, you won't have to do that. It is influenza season though, right? Yeah. It's kicking off, and Hawkeye, there's already some moderate disease activity in a number of states, so probably going to have a bigger influenza season this year than last year when it was virtually non-existent. We're already seeing more influenza out there, which masking is going to help protect. Yeah,
and I would like to say too, that was a great segue. During the respiratory viral season, influenza season, we have worn masks in the bone marrow transplant unit, the blood cancer, hematologic malignancy unit during that whole course now for the last couple of years. So it's a practice that we've been doing in selected populations. So we'll continue to do it. You know, still Australia has just over 500 cases total of their influenza, but I think we have differences in what we are doing compared to Australia. So I think the concern is there that, yes, as we are not masking now, we will more than likely be gathering indoors because we don't have a lot of restrictions in general in the United States. I think we really have that concern that influenza will kind of take off again this year. So absolutely get your influenza vaccine. You can get your either first dose, second dose, or third dose of COVID vaccine in that same visit. So go ahead.
So it is okay to go and get COVID and influenza on the same day.
And the vaccine.
Vaccination, yes. Not actually.
You don't want the infection. The vaccine, absolutely.
That could be bad.
It's safe.
Yeah. Aren't you glad I'm back? I can give you great questions
That's
like
awesome.
that.
Yeah.
Right, Jess, what else we got?
Taylor wants to know, it says, a common point I hear raised is that if the vaccine is so effective, why are the vaccinated so afraid of the unvaccinated to the point where we feel like we have to force them to get vaccinated? Shouldn't the vaccinated be safe given the effectiveness of the vaccine?
Well, clearly vaccination does make you a lot safer. We know our ICU numbers are 98% positive are unvaccinated, so no question about that. But you can still transmit disease, number one. Number two, the unvaccinated can really still transmit disease, fill up the hospitals, and make it harder to take care of everybody else. Because remember, hospitals aren't here to only take care of COVID patients. We still have heart attacks, strokes, cancer, cystic fibrosis, lung disease, emphysema, diabetes. And we have all sorts of diseases here in the hospital. What we know is the rate of death for the United States has accelerated. Our life expectancy has gone down. It's lower than it was since after World War II. You have to go find that statistic. It's gone down because we can't get people taken care of fast enough and time critical. And the reason is we are so burdened and full of people who have COVID. Imagine what would happen if we could reduce the number of COVID patients inside a hospital by 80 to 90%. That's what would happen if everybody was vaccinated. We would reduce the number of COVID patients by 80 or 90%. What a miracle that would be to healthcare and how much of an effect that would have on society.
Yeah, I mean, we've said we would prefer if 100% of the people who were in the hospital with COVID were vaccinated. Why? Because we know the overall numbers are going to be much lower. So I think that's important. And then kind of trying to clarify this question as to what do you mean by effectiveness? I assume here this question that it refers to effectiveness at staying out of the hospital and go to the ICU. The vaccines do that, and they continue to do that even months after vaccination. But, you know, protecting against infection, again, that's not what these vaccines are for. These vaccines are like a seatbelt. So you have your seatbelt on. It's not going to protect you from getting into a car wreck, but it will protect you from those severe injuries. That's what this vaccine does. But also, even if you are vaccinated and you do have some symptoms of illness, you still have to go get tested. If you are sick and it's positive, you have to stay home from work. You have to worry about then your children, especially if you're living in those households where the children are unable to be vaccinated if they're 11 and below. So there are a variety of reasons why people may be concerned about the unvaccinated, even if they're vaccinated. So I think it's important to take those things into consideration.
It doesn't take away from the credibility of the vaccine. And again, the vaccines protect against severe illness and death. We know that they're incredibly effective. They do reduce disease transmission, even with a Delta variant, and they reduce how long you're sick for. Dr. Brown, Dr. Brown, can I just say there are too many Chris's in this world?
Oh, yeah. I was talking with Chris Brown
Dr.
today.
Chris Brown, Dr. Jonathan Pike.
One of our favorite hospitalists.
You know, it's word salad. You come back from Colorado and your brain's all just a big mess here. So
it's thin air.
Yeah. So Dr. Pike, thin air, yeah, that's the only reason. Dr. Pike, the question I would have for you on Grapevine, you noted that a third to half of your patients hospitalized right now have COVID-19. How much better would it be if you could reduce that by 80%?
Yeah, so I think it would be, I mean, it's helpful for everyone. And again, like our staff and our hospitalist team and the APPs on that team are just working tirelessly to do what's best for the patients and keeping up to date on their knowledge. And I'd also give credit to our pharmacists who are giving us backup. And then that's the pharmacy department in Kansas City who's collaborating with them a lot too. So everyone is in our training, we're trained to push ourselves and work, but we don't do this for over extended periods of time. That's why we get vacations and things. So I think it would help everyone kind of refresh their minds, refresh their spirits if we were still seeing. I mean, I think one of the fun things about medicine is how you can see so much variety and so many different things and help people through those things. But when you see the same thing and it's COVID over and over, that kind of gets draining. To touch on one thing from the question from that most recent question, one of the comments that I've had that I've been dealing with in this community, I think the word that that stood out to me was afraid. And I think there's a difference there's a fine line between fear and caution. And I think people outside of maybe within the medical community, but specific also people outside the community blur those lines a little bit. And I think that's why things like this update are so important, to help people feel educated and confident in the resources that are available to them. Because when people mix that line between fear and caution, I think the different groups have kind of started to attack each other. And then that's where we get strains on emotional and mental health, which we don't want to cause those strains. And so that would be my response to that question is it's not confuse fear with caution. And I think as vaccinated people, we're not necessarily afraid, but we're trying to be cautious for all of the patients that we care for. And I would also say that I would hope that people don't feel attacked as we're trying to share, like you said, share science, share truth, and share facts.
Yeah, it is funny. Faith, hope, science. Together we can conquer just about anything. Jess. Oh, Jess, we can't hear you.
Rita has a family member who works with the heating and cooling system at a large hospital in Nebraska. He has talked about how they have control airflow rooms for the COVID rooms so that the air doesn't leave those rooms. Do we have those, and do most hospitals have those systems in place?
Yeah, that's a great question. I can tell you what we did at the beginning of the COVID crisis. We converted a bunch of floors to COVID, and it took took a fair amount of money. And we changed our air handler process so that we could evacuate the air out of those rooms, go through special filters, and take it out of the hospital so it doesn't recirculate. So the answer to that question is yes, we do a lot of that work. And Heath, I know you've had to do a special work around that in the ICUs.
Yeah, so we did convert 2 of our main medical ICU units to ensure that those rooms could have the negative pressure or air handling, as Dr. Stites alludes to. At the same time, we also know that just good keeping the door closed, and as long as people are wearing their PPE appropriately, which we've had plenty of that here, that you can also contain the virus and prevent patient to care provider transmission and or vice versa.
Yeah, and interestingly, even in this room, you think, oh, you guys aren't matched, you're sort of close together, but we have a negative airflow, and if you sit here for a minute, you'll feel the flow. There's a little bit of a breeze coming across you, and that's trying to keep you safe. So, the other thing I would point out is that we don't have disease transmission in the hospital. Why do we not have disease transmission in the hospital? Because we wear our mask. And that's the part that gets me all the time. You see all these folks out there, oh, masking doesn't work. I'm like, okay, folks, I know I've probably said this once or 300 times when I said it once, however that expression goes. Mm-hmm. We prove every single day the effectiveness of masking because we don't have disease transmission inside a hospital. Why do we not have transmission? Because we wear a mask. And every hospital is the biggest hotspot in the United States or in the world for collections of COVID-19 patients. Okay, Jess, last questions.
Okay, can I ask you 2 last questions?
Please.
Jamie wants to know, what happens to the virus when a person passes away? Does the virus die along with it, or how long does it stay active
That's a
in the
great
body?
question, Hawkeye. You're the ID guy who changes the names of diseases all the time to keep people like Dr. Pike and I confused. Go ahead.
That's right. Yeah, again, so typically viruses are not alive. That is a huge question and debate, not for this point in time. But, viruses can remain infectious for a long time, including coronavirus, if it's in that environment of the body, certainly less than if it's out in the environment. But we do know that there has been spread and autopsy and things like that. So our autopsy group has taken a lot of precautions, I think, as have autopsy groups all around the nation. But we also know, and Heath unfortunately can speak to this, but we do know that when a person dies, they do go through special treatments to keep their body contained so that they are unable to spread it as well. So we do know that you can still have infectious virus even after death, especially in those secretions from the upper respiratory tract and things of that nature. And I don't know if Heath, if you have anything to add too.
I would just agree with everything that you said.
So one of our big controversies originally was doing autopsies in COVID patients, and what type of infection control did the pathologist have to use? And because the patients weren't breathing, right?
Correct.
But they do use drills, use different things, and so at the end of the day, they have to use infection control precautions. Now, we don't think the virus lives forever. It has to have a human host because it needs its own blood supply, blah, blah, blah. But at the end of the day, we still have to take precautions even with autopsies and posts. So, okay. Jess, last question.
Okay, this is the last question, but I have to say, I know you were missed while you were gone because we have all these interesting, random questions that I think people have been saving up to ask you.
Yeah, are they about Star Trek? I know.
So nothing about Star Trek, but I'm going to save. I just want everyone to know I'm going to save these for follow-up Friday.
Okay.
But we're going to give the last one to Rebecca. Do you think this could be the last wave? She's heard that about 50% of the world is vaccinated. Could this thing mutate and get any worse?
Yeah, I don't think 50% of the world's vaccinated because there's a whole lot of people in the world that haven't been vaccinated. We're nowhere near that. I wish that number were true. 50% of the United States, yes. 50% of the world, I don't know about that. Yes, it can mutate and get worse until we get 80% of the world vaccinated, and we're a long ways from that, unfortunately. So we could see another wave for sure. But waves are dependent upon a lot of different things, one of which, are we masking? How much are people gathering inside? I mean, increasingly clear that outside events are okay. It's the inside events, even with the Delta variant, it's the inside events that are getting folks. So I think the question will come down to whether or not people are willing to continue to follow the rules of infection and prevention control, which travel with you wherever you go. And Hawkeye, they still keep you safe.
Yeah, certainly there could always be something that happens. We know the virus just can't mutate or change. That's just inherent in its replication process. So if it's replicating more, i.e. if there are more people who are unvaccinated, if there are more people who are immunosuppressed, who can't clear the virus for one reason or another, it certainly could change. We know that unfortunately there is a lack and a deficiency of vaccine available to a lot of populations in the world, South America, Africa, some on the Indian subcontinent as well. So unfortunately, there is just a lack of vaccine available for one reason or another to a lot of populations. We should work to get everybody vaccinated as quickly as we can. That will help reduce any chance of other surges, waves, any other variants. But I think one bright note, though, is that we have seen that Delta, in whatever environment it gets into, it does seem to outcompete other viruses. And in fact, I think it was the World Health Organization who decreased the variants of concern for some of these other variants, because what we have seen is that Delta really has emerged as the most fit virus or variant at this point in time. So this is what we're dealing with. We know some other ones have come up and been talked about, but those really haven't seemed to make headway in other populations. So this is what we're dealing with right now. The best way to move forward and get through this is to continue to vaccinate.
Yeah, the Mu variant, the Lambda variant, all those things. Delta variant overwhelms it. The good news is that vaccination keeps you safe. So keeps you out of the ICU, keeps you from dying. Final thoughts. Let me first turn to Dr. Latham. And thanks for being with us today, and thanks for all the great work you and your team, your nursing staff, respiratory therapy, social workers have done up in the ICU. It has been, to those of you who don't, this has been a really stressful time. I'm not in the ICU anymore. I was an ICU doctor for 30 years. I made it through the HIV crisis, but man, you guys, this has been a tough time.
And you're absolutely right. I will say that the last two stints in the ICU in end of July and end of August have been some of the most tiring weeks at the end of those 7 long days. But I will just say, as everyone has said here today, I want everyone to get vaccinated because, again, if we can reduce our COVID numbers in the hospital by 80 to 90%, then what that means is my colleagues in the ICU and we get to open up for all the critically ill patients across the region, Great Bend included, so that we can be here to provide that elevated level of care that some of our patients need across the region. And I would I agree with everything that's been said about wearing the mask too. I will say I have 2 school-age children. They wear their masks to school. They wear their mask anytime they go inside. And it's been nice that they both, in 18 months, have had 1 cold, which means mom and dad have also only had 1 cold in 18 months, and as opposed to every other, as we've all been through before. And so that's the last parting comments I'll have. Vaccines are good, just like everybody said, and we would like to be able to be opened up in our ICU to care for all the critical illness that people would like to transfer to us.
Can I just ask you one follow-up question? Are patients different with this wave? Are you getting a lot of denial that it's COVID, or people want to use ivermectin, et cetera?
It's not as rampant probably as one might expect, but we do from time to time get a request as to whether or not we should be using ivermectin, and we say, no, that is not going to help your loved one. We'll continue with the standard of care.
Yeah. Dr. Pike, final thoughts out in Great Bend, and live long and prosper.
Yeah, I would echo that, everyone, and so many people come to asking me, well, what are the risks of the vaccine? And then I say negligible, and certainly much less than any risk of the COVID infection that we don't know about. And so I would echo what you guys have said here. I think I'm grateful that this relationship between Great Bend and the health system was in place right as I started, and certainly before COVID happened. I think that's been such a benefit to everyone who's working hard here. And like you've given shout outs before to our nurses, respiratory therapists, APPs, everyone in the staff has been grateful. But then to have this support from Dr. Latham and the intensivists in Kansas City and it's not just for COVID patients. They are supporting us for any sort of critical patient that we can. And that's just been so meaningful to our patients and their families. And I look forward to having less COVID in the hospital and being able to provide higher levels of care here. And that's, so I guess my final thought is one of gratitude, and I'm looking forward to seeing what we can build here in the future with your support.
Yeah, we can't wait to see how we can transform the health of Kansans and around Great Bend, and what we can do, and lots more to come about that. That's a whole other conversation we need to have on this program.
Yeah,
Okay, final thoughts today.
I think things are going well. Cases are going down in the United States. Cases are going down locally. But it's still important, and it's time now to get vaccinated. If you haven't, please go get your first dose. Go get your second dose. We know that it can protect you. We saw that our hospitalizations are holding steady. We would like to see less in, as Dr. Stites had talked about. So if we get less people in, that's because vaccination rates continue to climb. So we will continue to endorse that, and please continue to talk with people and answer their questions about why is vaccination important. We've heard it here. Continue to try and get people to get vaccinated. But I would also like to give you this, Steve.
Oh, yeah?
As a welcome back.
Presents.
So let me tell you, yeah, you know what? I loved presents too.
Until you got this?
I got this. No, I had a long day last Tuesday.
You did?
It was my birthday.
Oh, well, happy birthday, and I missed
That's
that.
all right. I had a 6:30 interview. I had a 6:30 interview at AM. And then I did a panel at the Church of the Resurrection. So I didn't get home till like 9:30 at night. When I got home for my birthday, I saw that there was a present on my doorstep in the mail. I knew it was from my parents, so I was really excited because my parents are my biggest fans. But then when I got in and opened it up, I had understood now that I've been overtaken by you, unfortunately. And I did not want that gift, so thanks, Mom and Dad. This is what I got for my birthday.
This is awesome. Okay, it says Chief Medical Officer Dr. Stephen Stites, blue shirt from Star Trek with the Star Trek insignia.
Yeah.
That's the medical staff in Star Trek. Yeah. This is awesome.
I got a red shirt mug,
Thank you
by
so
the
much.
way.
You
so
did.
I don't know what that means.
Oh, God, you don't want the red shirts.
Nah.
Those are the ones that die all the time. It could be engineering, though.
Right.
Okay, we'll take that. You're a good man. Thank you. That's hilarious.
Thank my mom.
I love it. Thanks
mom.
to Mr. and Mrs. Hawkinson.
Yes.
The parents of Dr. Dana Hawkinson. You have a great son, and thank you very much. This is special. I love it, and you'll see it right here with me on many days. Hey, folks out there, tomorrow we're back with Jessica, both Hawkeye and I, to help answer your COVID questions. Plus, cancer screenings took a nosedive this year, despite the easing of COVID restrictions. We look at the long-term impact tomorrow morning at 8. Let me leave you with this final thought.
How are you today?
What does it mean to be a steward? What does it mean to be a steward? Let me ask you that question. If we were all better stewards, meaning we were taking better care of each other, and we would do a better job of making sure we watched out for everyone else's welfare, what would the world be like? How much faster could we get through COVID? How much better could we take care of ourselves? How much better could we take care of the world around us? What would it be to be a better steward in our world? Man, that would make a difference. We'll see you tomorrow.
Subscribe to our morning medical update and open mics with Dr. Stites podcasts. Now everywhere podcasts are available.